So thanks everyone for joining the meeting at the end of the year. I really appreciate being invited to give this talk every year, although it is extremely stressful because I know that in the audience there are people that are far more knowledgeable about tuberculosis than I am, but it also is a great opportunity to try and catch up on all the things that have happened in TV over the year, read all the things, all those bookmarks that you save that you say, I have to go back to that, and actually sit and listen to the conference sessions after the TB conference each year. So the TB Union conference was just last week. I wasn't able to attend in person, but as I told Jeremy, I've spent the better part of the last few days listening to the sessions, and I still haven't caught up, which is a wonderful thing. It just means there is tremendous amount of great work happening in TB. So this is not a comprehensive update. It's largely things that I think are interesting, cool, paradigm shifting, or that I happen to have time to read about. I will try at the end to do a rapid fire overview of some other topics, like drugs, vaccines, diagnostics. But there's a lot that's not in here, and I'll tell you some of what I wasn't able to cover. And I'll try and leave some time at the end because there are others in this room who probably were at the TB conference in person and who can provide additional updates. And I'd like to go back and revisit any areas that people have questions about. And please feel free to ask questions or tell me that I'm wrong if I misrepresent something. So this is the too long didn't read overview version of the WHO TB report. And the WHO report's published annually in November, and it gives us an overview of how much TB is there, how many people have died of TB in the past year. So this is data from 2023. And how we're doing in terms of treatment success for both drug susceptible and drug resistant TB. And so I'll go into a little bit more detail, but I've left I'm going to go quite quickly, and I've put the QR code at the bottom for anybody who wants more detail. So there were a record number of people diagnosed with tuberculosis in 2023. So we have surpassed pre-COVID levels of TB notifications. So 8.2 million people were diagnosed and notified with TB out of the estimated 10.8 million people with TB in 2023. This doesn't mean that TB incidence is going up because this is in the background of increasing population. So TB incidence is going down. Incidence rate, as I'll show you in a second, is going down, but we're finding more cases of TB, which is a good thing. Fortunately for COVID, unfortunately for TB, TB has reclaimed its throne as the single most common cause of death of a single infectious agent, which it had been TB had been surpassed by COVID since 2020 now. As COVID wanes, TB has taken its place as the single most common cause of death globally. So we have made tremendous gains. We have caught up in terms of where we were pre-COVID pandemic. The problem is there remains a substantial diagnostic gap. So pre-COVID, the diagnostic gap was about 3 million. Now we're sitting at about 2.7 million. So somewhere between 20 to 30% of people, and these are people with symptomatic TB. We'll talk about subclinical TB in a second, but 20 to 30% of people with symptomatic TB are not being diagnosed. So here are the raw numbers of the number of TB cases diagnosed. I think it's quite interesting to see like this. You can just see the precipitous drop in 2020 relating to COVID and how we're sort of gradually climbing our way out of that hole and probably picking up a lot of prevalent disease that was missed in the last 2 years, explaining these large numbers. So I think these are deaths. So there are 1.3 million deaths from tuberculosis. And as I mentioned previously, TB is now the single most common cause of death from a single infectious agent. This is the incidence rate. So this is as a proportion of the global population, what is the incidence of tuberculosis globally? So that rate is going down. However, it's going down very, very slowly. So back in 2015, the world's governments had gotten together and set out an end TB strategy to decrease TB incidence by 50% by 2025. We are falling far, far short of this target. So globally, there's been an 8% drop in incidence in TB since 2015, so far short of the global target of 50%. And unless we do something dramatic, we are not going to achieve our NTB goals. The Sub-Saharan African region has had the most dramatic drop in TB incidence, so 25% since 2015. So this is the global region with the most precipitous drop in TB incidence. This is most likely a reflection of the strength of the HIV programs in the continent. Probably has less to do with the strength of TB programs on the continent. So this is the sequelae of improving the diagnosis, treatment of people with HIV, and the background reduction in HIV incidence. I have to move my slides around a bit. I can't see my titles, but I think the title says that there's been, that there's quite a lot of heterogeneity in terms of which countries are seeing substantial drops in TB incidence. As I said before, it's mostly in Sub-Saharan Africa, and you'll see that South Africa has demonstrated one of the largest, if not the largest, decrease in TB incidence in the world relative to the 2015 baseline. And again, this is largely to do with the strength of the HIV program on the continent. But this is far from being universal. There are many other regions of the world that have had either stable or even in some places increasing TB incidence. And we'll talk about that in a second.
Ribka, sorry, the audio's just tailed off a little bit. Is it possible to either move closer or speak a bit louder or something? Sorry, it was okay in the beginning. It's got a bit.
How's it now?
Yeah, that's better. Yeah, thanks.
I'm going to switch off my Bluetooth to the computer and you'll tell me if that's better.
Okay, cool.
How's the sound now?
Similar, I think. Just try again. Sorry.
Okay, I'll try a third option.
This is the computer's microphone.
Okay, yeah, that's much better. Much better.
Okay. It might just pick up some background noise, but I'm in a pretty quiet place.
Okay.
Yeah, so I just wanted to put this into context that South Africa is doing very, very well in terms of TB incidence relative to our global comrades. So before I go to the next slide, does anybody want to hazard a guess? So in the last, ever since I've been following the global TB report, South Africa has been in the top 5 TB incidence countries in the world. Incidence, again, relative to the population per 100,000. Does anybody want to hazard a guess where South Africa was in 2023? And maybe Jeremy will have a prize for the person who comes closest.
Get a year's subscription to these bits of seminars. Perhaps put in the chat. What do people think? Take a guess.
Yeah, people, please take a guess. Where do you think South Africa is, and where do you think the top 2 countries are? I have to say, I was really, really surprised, shocked even.
Someone's put us as number 1. Someone else number 3. Got an 8. Number 1, 15.
Okay. And what are the top 2 countries in the world?
There's another 5 and a 6.
Okay, I'll move on. So the top 2 countries in the world are Lesotho and the Philippines. Now, I have to, I know that there's a substantial amount of TB in the Philippines, but I was surprised. I didn't realize it was that high, especially that high relative to other countries that we think of as very, very high burden, like South Africa or India or Pakistan, or, the countries that we sort of classically think of as the very high burden countries. So these are every year, WHO gives data on the 30 high incidence, so the top 30 high incidence countries, but now it's 29. Somebody left. I don't know if anybody wants to guess who left, who exited out of the top 30 high burden countries was Russia. Their TB burden has sort of halved in the last 10 years, and they're no longer considered in the top 30. So they're out. So sorry, at the bottom, the numbers kind of disappeared. So everything is still in the 200, and above per 100,000, or 100 and per 100,000. But so South Africa has dropped to number 8. And I'll show you in a second where we were 10 years ago and what a dramatic improvement there has been in TB incidence. This is not to say that it is acceptable. The TB incidence in South Africa is still overwhelmingly huge and a massive problem that we need to tackle. It remains I think, the number 1 cause of death in South Africa to this date. So I'm not trying to paint an overly rosy picture, just trying to say that South Africa has made gains. I was surprised to find out that Philippines, Myanmar, Mongolia have such high rates, especially Philippines, but I think that's, I need to read more. I don't believe, to answer Azim's question, I can't recall if Ukraine was in the top. I know Ukraine has quite a bit of TB. I don't know if at a population level they were in the top 30 previously, and I suspect now they probably don't have good data. But war and TB go hand in hand. There's been data coming out from Ethiopia and Sudan now that, given the instability in the region, TB is going up after many years of TB having gone down. So I fully expect that we will have some significant worsening of the TB incidence in Ukraine in the next few years. So this is what South Africa's looked like. So it was a high of 1,200 per 100,000 in 2010. And in the last 14 years, that TB incidence has dropped threefold. Okay, so how are we doing in terms of treatment success? So treatment success for drug susceptible TB has always been pretty good. As you know, the tragic thing about TB is that it's a curable disease, and yet more than 1 million people die every year of a curable disease. And so the outcomes for drug susceptible TB should be good, should be better than 90%. And globally, they seem to be around 88%. There have been really dramatic improvements in the outcomes for people with rifampin-resistant TB. I used to work at the Helen Joseph TB Focal Point back in 2012, and the vast majority of our patients would die and not complete treatment. I think we had 30 to 40% treatment success back in 2012. And I'll show you a bit further on in my talk where the South African RR-MDR treatment success is programmatically. It's sitting at around 60%, so in line with the global data. And so this is really good. And I think as our drugs improve and our regimens shorten and our drug supply stabilizes, we'll continue to see improvements in the RR-TB outcomes. This is interesting to me in an area of growing interest, in something that I also am starting to focus on in my own research, is that really this is largely almost a male TB epidemic, and even in parts of the world, this has always been true across time, historically, across regions, and even in sub-Saharan Africa, in Southern Africa, where the HIV epidemic is disproportionately affecting women, still more men have TB, and so there's some thoughts that there's some biological underpinnings, but a lot of it is social, structural, behavioral. It's about exposure, different rates of exposure to TB through occupational, mining, higher rates of smoking, more alcohol and substance abuse, potentially different patterns of social mixing, spending more time indoors in bars with a lot of people, less, more likely to be out and about in the world potentially. And so all of these things drive, and most importantly, lower rates of engagement in healthcare and lower rates of health seeking. So all of these drive this male TB epidemic, which I don't think we have really wrapped our head around. Like, the way that we think and all realize and recognize, that HIV is disproportionately affecting women in Southern Africa, I think we also have to wrap our heads around the fact that TB is really disproportionately affecting men. And this occurs throughout the care cascade. So men are more likely to be undiagnosed. This was clearly demonstrated in the South African Prevalence Survey. Less likely to seek out care once symptomatic, less likely to complete treatment, more likely to die. And so I think there really needs to be some sustained focus on the drivers around TB in men and what we can do. Different people have looked at the South African TB data. Your chance of having TB or positive TB test is higher. So it's not saying that a person with, I have to be careful how I phrase it, but amongst people who have a TB test in the South African NHLS, track system, male gender has a higher odds ratio of having a positive test than a person with HIV. So I would argue that if we need to focus our case finding going forward on any one group, it's probably men, men with HIV, men without HIV, just men. And people like Mamapudi Kubjani and other modelers have looked at the specific drivers of the male TB phenomenon in South Africa, and it's similar to the rest of the world. It's lower care engagement, but it's not all HIV. It's a lot of alcohol, tobacco, malnutrition, and care-seeking behavior. And so this is just to reiterate that, we think a lot about HIV, but now as we move beyond, and I'll make a case as we go, as I go today, that I think it's time to move beyond thinking about HIV alone when we tackle TB. I think we need to broaden our understanding of what the drivers of our TB epidemic are. I think we have done, as I showed you, a really good job of tackling the HIV-associated TB epidemic. And I think we've neglected people without HIV, people not in the HIV care cascade, to our detriment, because I suspect that's where a lot of the missing cases and undiagnosed cases and the transmission is coming from. And so there are many other drivers of TB in the world that actually contribute a higher proportion of the global TB burden: malnutrition, alcohol use disorder, smoking being the top 3 globally. And I think many people think that, that applies to places like India, where maybe there isn't a lot of HIV, but it also applies here. There's a lot of TB that has other risk factors that we don't really think about. Okay, so my favorite topic, subclinical TB, which seems to change its name every year. So this year it's no longer subclinical TB. The WHO announced that it's going to be called asymptomatic TB. So we'll call it the artist formerly known as subclinical TB. So just now, I think, in the past month, the WHO proposed a new consensus framework for TB disease. So by now, I think most of you understand that our historic paradigms around TB, being the sort of binary phenomenon that exists between a latent and an active state, are inaccurate. And then there are many, many states in between, number one. And number two, it's not linear. People move back and forth, up and down. And number 3, and most importantly, there probably is no such thing as latency. So that X should probably just go through latency. Let's get rid of latency and then figure out what the rest of the spectrum looks like. And so there's been a lot of work around this area, sort of trying to provide a phenotype of what these in-between stages are, between when you're initially infected and you get sick. What are the stops? What are the stations along the journey? And is it a one-way street? Is it a two-way street? And are there shortcuts and other ways around? And all of the above is true, which we'll talk about. So it's in this context that the WHO has tried to sort of unify all of the work around, what is TB disease and how should we describe it? And so the old definitions are on the left. These are the ones that are used in our case definitions. There's TB disease, there's bacteriologically confirmed TB, there's clinically diagnosed TB amongst those with disease. And of course, there are those who we used to have latent TB, those who are IgG or TST positive. And now we're moving away from the old definitions, and the new definitions, there's still, symptomatic TB that can be bacteriologically confirmed or unconfirmed. And they've added a new category of asymptomatic TB, which can also be bacteriologically confirmed or unconfirmed. And I think most of these intuitively make sense. I personally prefer the word subclinical. I'm not sure why they decided to use the word asymptomatic. I think there's a lot of good work that's been done to show that people who have subclinical TB, which by definition means they did not seek out care for TB. Somebody went to find them, right? And so in what context do we find subclinical TB? So for the last, historically, people went out looking for people with TB using mass chest X-ray campaigns. However, in the last, 30, 40 years, we've really stopped actively looking for TB through mass campaigns, and we passively wait for people to present to the healthcare system and report symptoms. Passive case finding for TB is a predominant TB case finding. There are situations where we actively look for TB. So that would be in the context of an active case finding program. So there are countries like Vietnam and Indonesia and others, and some sort of South Africa in the context of funder-sponsored, pilots, big pilots that are doing some active case finding with digital chest X-ray. So, and then in the context of prevalence surveys, when we go out and we look for TB, whether people are symptomatic or asymptomatic, that's when we find subclinical TB. So it's people who did not come to the health system complaining of TB symptoms, but where the health system went to look for them for some reason. The other time we sometimes find subclinical TB is in the context of household contacts. So I think a lot of these folks are not truly asymptomatic. If you really, really drill down, do you feel your best? Often it just means that they're not really coughing. They don't feel so sick that they have, want to take time off and go queue in the clinic, but often they have something. But for reasons known to the WHO, they chose the term asymptomatic TB. And so that's kind of what we're going to be using going forward. And within that group, there are those who are bacteriologically confirmed, meaning they were able to provide a sputum or some other test, and we found TB. And then there are people who are unconfirmed, and that's an interesting group. So all of us who practice medicine, are very comfortable making clinical diagnoses of TB in sick people, in whom you may not prove that, advanced HIV. But there is a phenomenon of bacteriologically unconfirmed asymptomatic TB, and a lot of debate about how important that is. And that's one of the things I kind of didn't realize before this year. And so we'll talk about that a bit. And there are various reasons why this could be. So the WHO's focus is largely on these sort of programmatic and pragmatic definitions of symptoms and bacteriological confirmation. But it may seem not that important, but it's actually going to have huge implications for how we quantify TB, how we count TB, what we estimate that TB burden is. So that 10 million cases of TB that I told you, that is largely symptomatic TB that we're talking about. And in prevalence surveys across the world, whether it's South Africa or other countries that have done prevalence surveys, we think about 50%, 40 to 50% of people have subclinical or asymptomatic TB. So starting next year, WHO is going to change their reporting structure. There'll be the normal estimates that we're used to, the 10 million. And then there's going to be another estimate, sort of the total burden that includes asymptomatic disease, and will be largely based on modeling work. And so that'll be very interesting. So it'll be a big change, and we'll be trending all of them. But so those definitions are the WHO definitions, but others in the research space have really tried to go beyond just asymptomatic, symptomatic, and have questioned many things. So they've questioned this notion of latency. What is latency? Is there such a thing? And are we not conflating a diagnostic test with an actual clinical phenotype? So what we're saying is there are people who have a positive TST or IGRA. Well, we don't know what that necessarily means, because the vast majority of those people do not go on to have TB. Only about 2 to 3% of people with a positive IGR or TST go on to develop TB. So what that test is just a test of immunoreactivity. It's like your CMV IgG. It's saying you were exposed to TB at some point. And it's not a particularly great predictor of who's going to go on to develop TB. So now Anna Cousins and others have proposed these sort of consensus definitions and moving away from this concept of latency. So let's call TST and IGRs what they are. They are tests of immunoreactivity. They demonstrate the presence of immune memory cells to a current or previous TB infection. The vast majority of those people will self-clear, never go on to have TB. And we don't have a test for that. And so we can't define it. They also propose other definitions that, we need to include pathology. Does the person have TB based on imaging or tissue or histology or exam? Is there a host response to demonstrate TB disease? And is there evidence of viable MTB? TB that could grow if isolated and cultured appropriately. And so that doesn't just mean bacteriologically confirmed TB, because there's this whole group of people in whom we don't always confirm bacteriologically that they have TB, but actually could be harboring viable TB. And I'll talk about that a little bit more. And so there's this group that published this consensus framework where they think that we should be very specific about what we're measuring and use these terms in the context of TB disease. So why? What are the arguments for this? Well, as I mentioned, immunoreactivity is a poor predictor of who's going to go on to have TB. So fewer than 3% go on to TB. Most will self-clear, and we don't know. We don't have a test for that. We have no measure of clearance. And currently we have no measure of viable TB, but I'll talk to you about some indirect measures. And so in addition to asymptomatic TB, which is kind of the new buzzword that the WHO is proposing, this other consensus framework published by Anna Cousins and others really pushes this idea of viable TB, that we need to develop tests for viable TB. We need to measure viable TB. We need to trend the global burden of viable TB. That's what we're interested in. So why does this matter? Why is viable TB important? Well, from a healthcare worker or patient point of view, it's really important because not everyone that we see is cut and dry. And I'm sure all of you have probably seen these patients that don't quite fit well. And as we do more active case finding for TB, we're going to find more and more of these people who don't really neatly fit into a paradigm of active TB or whatever is before that. And so these are two examples that were shared at TB Union. And the first is a case of these are from Hanif Ishmael has a cohort that he's followed over 5 years and is recently published on, or there's a preprint. These are individuals in South Africa who are household contacts of a family member with TB, and they did not receive TPT. They were all HIV negative and not TPT eligible before, up until our recent TPT guideline change. So for that reason, this group of people didn't receive TPT, and he followed them over 5 years with serial X-rays, sputum sampling, PET scanning, etc. And so here are some of these people that don't fit. So case number 1 was asymptomatic, had a prior history of TB, had a chest X-ray abnormality, sputum was expert negative, cultured negative, PET scan had some avidity around the nodes, didn't look, chest X-ray, sorry, was a bit abnormal, and the PET scan was also abnormal, but they did sputum sampling, couldn't find TB. Should this patient get TPT? Probably, just on the basis of the fact that they're a household contact, but at the time it wasn't in the guidelines, so this person didn't get TPT, they were HIV negative. There was no evidence of microbiological disease, so they were just watched. And then 2 years later, this person became gene expert positive and had progression of their progression of their disease on imaging and PET, but I believe remained culture negative, right? So this is where, it's messy. We don't always know how to categorize these patients. Is this viable MTB? Is it not viable MTB? What is viable MTB, So that's one case. And then another case is a patient, also a prior history of TB. So this is the second one on the bottom. Household contact, had the chest X-ray, had the PET scan. So this all, again, was asymptomatic. This person was expert positive and culture negative. So again, this question comes up about the viability of the TB. And whoever evaluated this patient decided not to treat them for TB. And they were followed with serial PETs, and nothing happened. This person remained culture negative and TB negative over 4 years of follow-up. So, how do we categorize these patients? Who has viable TB, who doesn't? And I think that's going to be an active area of research. So from a just purely clinical point of view, we need to understand what is viable TB. And we need to know how to treat people who fall in these in-between zones. What are the optimal doses and durations? And I think there are those who would argue, let's just take a public health approach, give everybody 6 months of TB treatment, call it a day. But there's good data to suggest that people with asymptomatic TB don't want to take 4 months of yucky TB treatment, I fortunately haven't had to take TB or TPT, but I've had friends and colleagues with TB who tell me that and patients obviously who say it's pretty miserable. So I think it's not a simple thing to take someone off the street who has no symptoms and tell them, here you go, take 6 months of TB treatment. And so the TB treatment completion rates in asymptomatic TB are quite low. So there are at least two trials that I know of that are looking at this, one in China that's looking at 4 months of TB treatment relative to 6 for asymptomatic bacteriologically confirmed TB. And then Hanish Ismail and that group in the UK are looking at people who are bacteriologically unconfirmed. So this other group that's culture negative, but has other indications that they might have TB based on chest X-ray or PET scan, and comparing no treatment, for which there's equipoise, to 2, 3, 4, 5, 6 months of treatment. So I think these are really interesting questions. Obviously, a separate and related question is, if we use expert alone in our active case finding strategies, as we will, and we don't have any tests of viability, we're likely to overdiagnose TB. And so that is a problem that we need to start thinking about as we expand our active case finding efforts. So let me see how I'm doing on time. This is a study that I think is really, really cool, but it takes a little bit of focus and concentration. So like if you're texting or WhatsApping, this would be the time to like really pay attention to the figures, and it's worth it. I really think it's interesting. So I'll try and walk through it. So this is that same cohort that I was telling you about. South African household contacts of people with TB without HIV, the baseline symptom negative, and did not receive TPT because it was not in the guideline when this study started 6+ years ago. And they were followed up with serial sputum testing at baseline and over up to 5 years of follow-up, baseline chest X-ray and PET scan, and then serial PET scans over time. And so there were 80% TST agra positive, which is quite high. And then in this preprint, they demonstrate how many cases of TB you would find depending on what algorithm you applied to look for TB in this group. So the first algorithm is our old algorithm, where imagine we just did symptom screening, which was, what we did up to about 2 years ago. Even in household contacts, we just did a symptom screen. And if they were symptom negative, that's it. We never saw them again. And so, in this group who are symptom negative, so these 250 people, you would have, by definition, diagnosed 0 cases of TB. And then the WHO says, okay, it's not enough to just do a symptom screen. You should do a symptom screen and a chest X-ray. And if the chest X-ray is abnormal, you should get a sputum for TB. So that first bubble chart is, how many cases of TB you would find if you followed the WHO algorithm. So 15% had an abnormal chest X-ray, and one of those people had culture-confirmed TB. So if you follow the chest X-ray algorithm for household contacts, in addition to, we're not looking at the symptomatic ones. We've taken those out. In the asymptomatic group, you'd find 1 case out of 250. Okay. Well, in this study, they did pretty aggressive sputum sampling. Everybody got 3 baseline sputums, and if they couldn't produce spontaneously, they were induced, and they got expert and culture. And so at baseline, by doing that intensive sputum sampling, they found 6 cases of TB. And so it tells you already that chest X-ray is really not enough to tell us who needs TB or not. Certainly symptoms are not enough to tell us who has TB or not in this high-risk group. Okay, now we follow people over 5 years. How many people develop incident TB? So 5 years of follow-up with serial sputum sampling, 18 people become expert or culture positive, 7% overall. But there's some question in there about how many, some of them are expert positive, culture negative. So for the study purposes, they said only 5% developed TB. So they're using a very strict definition of culture positive. And so this is where I feel like the figure's confusing, but worth trying to really look at carefully. What he's trying to communicate in this figure is, as a proportion of those who had baseline lung abnormalities on imaging, can you use that to predict who is at future risk of developing TB? Well, the answer is yes. So the PET scans seem to predict years before people develop TB that they are at higher risk of developing TB. So 50% had PET abnormalities, and they classified PET abnormalities in 3 categories: suggestive of TB, suggestive of inactive TB. So these are people who look like they had sort of scarring from old TB potentially, and other pathology not suggestive of TB. And 43% had normal lungs. Sorry, those percentages don't add up. So I think it was more like 55, 45. And so then what happens? So in the subset that had PET scans that were consistent with TB, 35% are eventually diagnosed with culture positive TB over a 5-year period. And remember, these are all asymptomatic, all culture negative at baseline. Of those who look like they had inactive TB, so scarring, 3% go on to develop TB. In those who had other parenchymal abnormalities, 1% go on to develop TB. And of those who had normal lungs, 2% go on to develop TB. So am I suggesting that everybody should have a PET scan? No, I'm just saying that our current tests, be they symptom screening, IGRA testing, even sputum culture, are not really good predictors of who already has viable TB. And so there's been a lot of work around biomarkers and other things to try and see how can we predict better than IGRA and TST. And unfortunately, the biomarker work around the RNA transcriptomics and so on, none of them seem to be even as good as IGRA. So we don't have a good test. PET actually seems to work better than anything, but of course not feasible. But we need alternate markers that can pick up whatever it is that PET is picking up years before people develop symptoms or become culture positive. And that's what we need, is a test of viable TB. Okay, why else is this concept of viable TB important beyond the patient, their treatment, and prediction? Well, it's important for preventing transmission because identifying this group is crucial in that those images that I showed you. All of these patients, all of them, all the 18 remained asymptomatic throughout. So, if we want to pick up early TB and interrupt transmission, we really need to have a better understanding of who has viable TB so we can find it and interrupt earlier. Current models estimate that 50% of TB transmission occurs during this preclinical, subclinical period before people develop symptoms and seek out care for their symptoms. And there's a lot of thought that the reason we're not seeing really sharp drops in TB incidence is because we're not tackling that group, right? We're picking up sick people, we're picking up people with HIV, but we're not really getting to the bottom of the iceberg of the group that's likely transmitting. And so these are images that show like the trajectory. So, 1 year post-infection, most people are blue, they're newly infected. Some people are yellow, they have minimal disease. Some people are transitioning between zones. And then over time, most people clear, right? Clear or recover, they're gray. And a small proportion of people will develop active clinical disease. But as a proportion of everyone who is infected, it's a very small group. And trying to find this needle in the haystack is hard. And that's one of the challenges. So as I mentioned to you, going forward, we are going to try and better describe the burden of viable TB globally. So up until now, I'm sure all of you have heard the statistics. 1/3 of the global population is infected with TB. Well, what we mean is 1/3 of the global population is immunoreactive, has a positive TST or IGRA. But as I showed you in the prior slide, most of those people will go from the blue bar to a gray bar and will clear or recover without ever developing disease. So it doesn't really mean anything to say 1/3 of people, are immunoreactive to TB. We really want to know how many people have viable TB and are at risk of developing TB. So some folks, this was an interesting presentation at Union, tried to sort of use other indirect measures of recency of infection and progression to model the global burden of viable TB. And they use different inputs to try and understand what that is. And one thing that people have often, where they considered like one of the ways of measuring incident TB rates and changes in incident TB rates is to look at TST rates in children, young children under the age of 5, because those are people who have not had time to be, they've only lived a short period. And so if they're, the rates of TST positivity in children under 5 are like the canary in the coal mine telling you how much TB is in your community. And so if you see TST or IGRA positivity in people under age 5 go down over time, it indirectly tells you that TB rates in the population are going down. But those are probably underestimates because children are not exposed to TB as much as adults. So anyway, this is all modeling mumbo jumbo that I don't understand. But they eventually came to the conclusion that 2% of the global population is infected with TB every year. And currently somewhere around 5 to 8% of the global population has viable TB at risk of progression. So these are all models and estimates. We don't really know because again, we don't have a test for this thing. Well, how do you measure viable TB? And this is a bit of a random but cool study. And apparently there's lots of historical precedent for it. So this is a group at Satvia in Cape Town that did autopsies on people who died with no clinical evidence of TB disease. These were largely people who died of car accidents or trauma or other things. So they did not have TB. There was no clinical history suggestive of TB. And there was no macroscopic clinical evidence of TB when they examined tissues or chest x-rays. And yet, and I found this shocking, I was wondering if they missed a decimal point, 64% had TB detected on a PCR, an expert, in lymph nodes. And I thought that can't be true. Like 64% of people who die of a car accident in Cape Town have evidence of TB on the lymph node. And then there's all this historical data. If you go back to the 1800s and the early 1900s, again, they did these autopsy studies and they found 10 to 50% of people who died of non-TB causes had viable TB. And they were using an even higher standard for the definition of viable TB. They were taking the tissue from the autopsy and implanting into guinea pigs, who are the best test case for, because they develop TB very rapidly. And so that's how they were demonstrating that these people who had no clinical evidence of TB had viable TB. So this is one indirect measure of who has viable TB. So again, we need tests that tell us about viable TB. Sorry, these are some notes that I was making, but some folks were suggesting a provocative idea, like, are we at the time where we can do, what do you call test of, it's been done in like typhoid or malaria or flu, where you infect people intentionally and then monitor them and then give them the treatment. So is there equipoise or enough public health need to do those types of trials in TB? That was a topic of discussion. I don't know what the answer is. So now in my last 15 minutes, I'm going to take a page out of Paul Sachs's annual ID review and a really, really rapid review of a whole bunch of other things. And I'm just going to speed through it. I can come back to anything that people want to focus on a bit more. So these were two really cool papers that came out in the last year that get into how TB is spread and really go against a lot of our dogma that, we always taught that cough generates aerosols spread TB, and TB is airborne, and all of that is true. And of course, a single cough generates a much larger force of, aerosols and dispersal of TB bacteria. But this group in Cape Town demonstrated that although coughing does produce more aerosols, overall, because we breathe more than we cough, more infectious aerosols were produced during tidal breathing than during coughing. And so that's really quite an important and striking finding. And another finding is that when people looked at the bacillary load of TB in people with symptomatic or asymptomatic TB, people with asymptomatic TB do seem to have lower burdens of TB, but because they're out and about, living their best lives, working, using transportation, and they have much higher rates of social contact and are, in the community because they're not sick, despite the fact that they have lower bacillary burden of TB, we still believe that people who have asymptomatic TB likely contribute disproportionately to spread. Okay, other important papers that came out this year. Hopefully everyone saw this. I know it was shared on the ID WhatsApp groups. Dexamethasone in TB meningitis in people with HIV. So this is like the complete opposite spectrum from asymptomatic TB. This is the most severe form and deadly form of TB. And so the sort of historical paper going back all the way to 2004 showed that people with TB meningitis had a reduction in mortality when given dexamethasone. And so that's the basis of the guideline that recommends the use of dexamethasone, but there's always been a question about, well, what about people with HIV who may have other co-infections or other reasons why steroids may or may not help. And so it took 20 years to finally publish the study in HIV. It's sort of criminal that it took so long to get this done. And the study of dexamethasone in TBM, this time specifically for people with HIV, failed to show mortality benefit. There was no evidence of harm, and so it's still likely reasonable to use steroids in people with HIV, but there was no evidence of a mortality or other benefits. Although it is important to note that there was substantial proportion of people in both arms who received open label steroids, which could have masked an outcome difference. And so I'd be curious if we have time to discuss at the end if and how this has changed people's practice following the publication of these results. There are other interventions that are being tested for TB meningitis. So higher doses of rifampicin. So rifampicin has very poor penetration across the blood-brain barrier. And so there's a thought that potentially with higher doses, 15 mg or 30 mg per kg, we may have better outcomes. Or maybe we need drugs that have better CNS penetration, like linezolid or fluoroquinolones. There are other host-directed therapies that are being trialed, indomethacin and aspirin, both in children and in adults. And And there are case series describing other immunomodulator therapies like infliximab, thalidomide, and anakinra. This is one particular paper that shows a patient who had a persistent tuberculoma that just after years of TB therapy and steroids that was unresponsive, that just shrinks over a few months of infliximab therapy. So this is something I came across that is from Tom Boyles and others, which is a very cool online calculator and TB meningitis diagnostic prediction model. So you go online and you put in the white count and cell differential and glucose and CRAG positivity, HIV status, and it tells you a percentage likelihood that the person has TB meningitis. So I thought that was kind of cool. Okay, quick update on RIF-resistant MDR TB in South Africa. So the incidence, both in terms of numbers and actual incidence rate, is dropping. So the numbers are dropping and the incidence is dropping. And so we're doing something well, and we're having significant improvement. We've also seen significant improvements with the treatment outcomes. So 60% have treatment success, which is terrible if you compare it to drug susceptible TB, but really good if you see where we were a few years ago, where I mentioned to you, 30% treatment success back in 2010. So we've doubled our treatment success. So in 2023, South Africa implemented the BPAL-L regimen, so bedaquiline, patonimid, linezolid, and levofloxacin for people with rifampicin-resistant TB. There's been a lot of interest in trying to understand what the baseline rates of bedaquiline resistance are. So we didn't know for a long time because we're only really looking for bedaquiline resistance in people who are failing our MDR therapy. But in the past 6 months to a year, we're now doing systematic baseline testing, looking for bedaquiline resistance at first diagnosis of rifampicin-resistant TB. And so we have better estimates of what primary resistance is. So primary resistance is that the resistance that you had at the time you were infected versus the resistance that you develop on treatment. And so there's a lot of regional variation. So as low as 3% in the Eastern Cape, as high as 10% in the Western Cape. If anybody in the audience is from the Western Cape can tell us why there's so much more bedaquiline resistance, I'm really interested to hear. Or maybe, these could be artifacts of the testing, coverage or who's being tested. But it seems to average out around 6.5%. So it's high, right? So that's as high as our rifampicin resistance rates amongst people with, TB. So as a percentage, I mean. So what's really interested is that most of the people who had bedaquiline resistance were fluoroquinolone susceptible. So we cannot just look for bedaquiline resistance in pre-XDR patients. We have to look for bedaquiline resistance up front in people who have RIF resistance. We can't just look for bedaquiline resistance after we've demonstrated pre-XDR fluoroquinolone resistance. And the prevalence of linezolid resistance is very, very low. Linezolid is a lot more robust to developing resistance mutations. Bedaquiline seems to have a lower threshold for developing resistance. And so last year or 2 years, we've been doing routine expert XDR for fluoroquinolone resistance testing in everybody with RIF-resistant TB. And then starting this year, everyone who has, RIF resistance should have targeted next-gen sequencing and phenotypic susceptibility testing for bedaquiline upfront, so that we can have a much better understanding of what, how, the emergence of bedaquiline resistance. There was some big news that came out this year. Just a few months ago in August, those of you know Francesca Conradi, who for many years was based at CHRU in Johannesburg, is now at the WHO, led the Beat TB trial. And so this was a very cool, very pragmatic trial. So they enrolled children, people with HIV, pregnant women, advanced disease. It wasn't a cherry picking the best patients trial. It was really everyone, all comers, and whether they had fluoroquinolone susceptible or resistant TB. And they gave her a 6-month oral regimen that included delaminid and clofazimine, did not have patonimid, And they did different things depending on whether or not you had fluoroquinolone susceptible TB, and the outcomes were good. And why is this important? You could say we have BPAL, who cares? Well, there are a lot of people who are not eligible for BPAL because we don't have safety and dosing data for protonamide in children, in pregnant women, etc. And so now we have in the evidence base for a good oral regimen for pregnant women, for children, the BDL, that regimen that's there. And then the NTB trial was looked at 5 different 9-month oral regimens for people specifically with fluoroquinolone resistant TB. A lot of them looked like the TB regimen. The one that's interesting was bedaquiline, linezolid, moxifloxacin, and PZA. So it took out no delaminid, no protonamide, which are the 2 drugs that I think many TB programs have a harder time securing. And so that regimen also had good outcomes. So the WHO released a rapid update earlier this year saying that these 2 oral options are acceptable for the treatment of RR, MDR, or fluoroquinolone resistant TB. And there's a new guideline that's expected next year. Jeremy, I'm almost done, I promise. So TB vaccines, huge pipeline, and they come in many, many, many flavors. So the flavors of vaccine are prevention of infection. So this would be like a BCG type vaccine where you give it to an infant or a child so they don't get TB. There's prevention of disease vaccines. So this you would give to people who have TB infection, which right now, again, we don't know who has TB infection, but we use IGRA or TST as a proxy. But we've already talked about why that's problematic. But prevention of disease is a vaccine given to people who are IGRA positive to prevent disease. And then there's prevention of recurrence that's given to people who've had TB to prevent the recurrence of TB. So vaccines can come in all these flavors, and we don't have one right now that has a good evidence base, but we have several that are in phase 2 and phase 3 trials. And so the 2 that I'll highlight are the MTB-VAC, which is being used as a prevention of disease and the prevention of infection in infants. So it's being given to infants without HIV at birth. So, and compared to BCG, so 3,000 infants, phase 3 trial. And then it's being given as a prevention of disease vaccine in a phase 2 trial in adults and adolescents with and without HIV. And then the one that is in the largest trial is the M72. And so that's phase 3, ongoing, 20,000 adolescents and adults with and without HIV. It's a prevention of disease vaccine. So it's being given to people who are IGRA positive to prevent TB disease. And the primary endpoint will be number of people in whom TB disease has been prevented. And they're powered to demonstrate a 50% efficacy. And so we expect that's all enrolling, 52 sites across the world, and expect results in 2028. So it's an exciting time for TB vaccines. Tongue swabs, it's an irony since I'm doing a lot of tongue swab research, but I didn't have time to spell it all out for today's talk. But I watch this space. I think it'll be interesting next year. These are the take-home points. The tongue is better than the mouth. So, people spend many, many years swabbing the mouth and the yield was really poor. And then a couple of years ago, they figured out that the tongue is really where we should be looking for TB, probably that TB gets stuck in the pillae in the tongue. And overall, tongue swab testing does seem to have lower yield, although a lot of groups are working out, how can you optimize specimen pre-processing, because it's very different from processing sputum. But the argument that's being made for tongue swabs is that, in the same way that COVID antigen testing, because it's quick and cheap and can be done easily, could overall diagnose more people than a PCR, which is more expensive. Specifically, in countries where you had over-the-counter COVID antigen tests, anybody could test themselves, an easier to perform or more accessible tests can find more people, even if it's not very sensitive. And so I think that's the argument that's being made for tongue swabs, that, it's not going to be an optimal test for people who can produce sputum, but because so many people can't produce sputum, and it's also not feasible to it takes time to coach people to produce sputum, that if we wanted to take a test out into the community to do mass testing, maybe that's a use case for tongue swabs. So on one end, people are trying to optimize the pre-processing, and on the other end, people are really trying to figure out, like, what is the use case for tongue swabs? Is it for, mass community testing? Is it for children in a hospital who can't produce sputum, or people with HIV who are unable to produce sputum, or is it for, subclinical TB? Like, what is the use case? And so I think in the next couple of years, we're going to see some interesting data about that. And that's it. I've run out of time. So these are the things that are interesting that I didn't talk about. There's a cool paper, the cool study about urine expert in people with HIV. Does better than lamb. I don't think that would be a surprise to any of you but you have to get, you have to centrifuge the sputum, etc. Some work around CRISPR and cell-free DNA, stool expert in people with HIV, not great, probably 10% increment. The pan-TB trial results, which I didn't get into, there are new skin-based antigen tests that are now commercially available, and these are alternatives to TST, and they seem to perform as well as IGRA and TST and are cheap. And so I think we're starting to see some use cases around that come out. And some advances in therapeutics around developing and testing long-acting injectable TB drugs, either for TB preventive therapy, like equivalent to, cabotegravir or lenacapavir PrEP, or potentially for TB therapeutics. And so there's some work around bedaquiline. There's like an injectable formulation of bedaquiline. There are injectable formulations of rifamycins, and then some other drugs that, don't have real names yet. And then a lot of work around digital chest X-ray CAB, and probably and some stuff around lots of other things that I didn't have time to get into, but happy to talk about. So I'm sorry I went out of time, but thanks for being such a good audience.
Awesome stuff. Really, really, really amazing to go through. And I mean, I used to joke with you, Ribka, 5+ years ago, I used to mock the TB world, saying that, it feels like nothing's ever come out of it in about 50 years. And it just shows, this, I think your talk today showed how different it is now, and how wrong that sort of criticism would be today. I mean, there's a huge amount of really interesting stuff coming out, and really nicely summarized for so much of it. Really, really interesting. I'm just looking through the chat. Pisana was just saying, just a small correction. She said targeted next-gen sequencing wasn't implemented in 23, but she plans to implement it next year. And then
sorry, Frizana, that's a big I got excited.
No, I'm joking. And then Nasisa had a couple of questions. Nasisa, do you want to maybe just unmute and ask if you want? Because the first one, I can't remember the context now.
Hi, Jeremy. Hi, Ribka. Can you hear me?
Yeah, I got you here.
Okay. So it was the study that was looking at asymptomatic TB people that were contacts of, so following them up for 5 years. So that study, I think the author is Ismail or something like that. So my question is, so as they followed up these people and some of them developed TB, were they able to sequence that it was from the original contact? So they didn't develop TB from some other exposure, but they developed TB from that original exposure from their contact.
That's a good question. I didn't see that in this paper, but a lot of work is being done around that question by other groups. So there's a global consortium called Report, where they have the same protocol, and they follow household contacts from 2 to 3 years after exposure, and to look for like biomarkers and basically all of these things for these markers of early TB, and they follow that same protocol in multiple sites in South Africa and India and Brazil and China and many countries to try and again make sure that any biomarkers that we find work in different settings. So there's that group, and there are others. So the dogma is that even when in super high incidence settings like South Africa, that often when you find co-prevalent TB in the same household, it's not always linked. That sometimes the households share like risk factors for TB, but it's separately acquired. And so there's some genomic data to suggest that. A lot of it is older and comes from like less before we could do like whole genome sequencing where we could get really, really precise. So I think there will be more data on like household linkages. So some people, some co-prevalent TB in the household is separately acquired because people share the same environmental, social, genetic risk. Some of it a lot of it obviously is transmitted in the household. So I don't have a good answer for you, but yes, it's a really interesting area of research.
Thanks, Ribka. Should I ask the other question as well, Jeremy?
Yeah, I think so. So just thought in. So we don't have an unknown case to follow this, so we can take questions for a bit. We do have a bit of time. So go ahead, Ms. Lisa.
Thank you. So the latest guidelines, and correct me if I'm wrong, certainly for people that have had, this is people living with HIV. So if they've had TB in the past, they need to have a TB net with their annual viral load for the next 2 years. And I think as well, the annual viral load now comes with a TB net. So that's a slightly different group, that's fine. But the ones that have had TB before, so how is one supposed to then respond to, you've had TB before, you are now in these 2 years, annual viral load, you are asymptomatic and the TB net is positive. Is it not taking us back to that same thing of, now having to tease out, is this active TB or not? Or is this the TB net just being positive because it may remain positive for some years?
Do you want the public health response or I have a single individual patient in front of me response?
Maybe
I
both,
think there's two.
because I think even in the public health space, it does open a conundrum because a lot of the great majority of these patients are under the care of nurses.
So the data for this came from the TUT study, Targeted Universal Testing for TB, and in TUT, 3 groups were tested: people with HIV, irrespective of their prior history of TB, household contacts who were in the clinic for whatever reason, and people with a prior TB who were also in the clinic for whatever reason. And so the premise behind TUT was, we know that symptoms are not sufficient, right? A lot of people with TB are not coming to the clinic with symptoms. And then the only other way that we have to find TB right now is chest X-ray, and that's not being implemented at scale. And so the reason for the rationale for TUT was, well, South Africa has the capacity to do a lot of NAT testing, right? Like really high throughput NAT platforms and the ability to scale up NAT testing. So why don't we just do that? Since we can do that, let's do more NAT testing, and instead of targeting symptoms, let's target risk factors. And so there were fairly high, yields in these 3 groups. So people, overall, it was about 6% of people in clinics in these 3 categories had TB, whether or not they had symptoms. The highest proportion were in people who had a positive expert, were in those who had a prior history of TB. And so, it's troubling because this is a group that we know can have persistent, PCR positivity for a long time, but it's also a group that is extremely high risk for TB recurrence. And so I think the public health response is, a lot of this TB is probably real, and this is a very high risk group. And until we have a test for TB viability, we should test these people and treat them. The individual clinical responses, if this were my mom, I would want to probably, definitely get a chest X-ray, do a detailed symptom screen, and a culture. If the person were truly asymptomatic, a culture to ascertain whether or not they had TB. But that's, that's not in the guideline. And others should feel free to speak up and talk about, and I think this is a controversial issue. The reality of how TUT is being implemented is because, people with prior TB are not a readily identifiable group, and household contacts are not a readily identifiable group in the clinic context, that de facto TUT is actually only just being implemented in people with HIV. So what has happened is the way the trial was done was systematically screening people for these risk factors. But in reality, what's happening at the clinic level is, everybody who's coming in for their viral load test is getting a sputum test for TB along with their viral load. And it's interesting because that's not actually the highest risk group for TB. Like, people with largely women, right? 60 to 70% of that group is women. Women with well-controlled HIV are not our highest risk group for TB, but because it is the most readily identifiable group, that's how we're deploying TUT. And so in provinces that are really massively scaled up TUT, like KZN, you've seen yields just drop. So like they're seeing like 2 to 3% TB positivity. The Western Cape's still like always 14%, no matter what. But I think there's a lot of debate about how, yes, there's asymptomatic and subclinical TB, but how do we go and find these people? I think that's an open question.
Cool. And Tandy, I don't know if you want to mention it, Tandy Flamini, who's put a comment in the chat about what's in the guidelines about looking for RIF and that. Tandy, you're welcome to unmute if you'd like. Otherwise, we can, if you'd prefer, we can just have a look at the comment. And while we wait for that, so Fazana's got a hand up, and so does Zodra. Fazana, do you want to go ahead? You should be able to unmute.
Yes, thanks. So just a couple of points about the testing amongst people living with HIV. Ribka, in the TUT study, was cases more seen in people who were uncontrolled in terms of the viral load, or was it irrespective of? That's one question I have. And then just from a public health perspective, I know in terms of the ease of collecting a sample, when you have a patient in front of you, it's easier to just do everything when they're there instead of you doing X now, then they're going to come back and then you're going to do Y and then they're going to come back and then you're going to do Z. But, the higher risk, in my understanding, it's not just people living with HIV, because in the prevalence survey, we found more TB amongst people without HIV than with HIV. So in this instance of what is in the guideline and in terms of testing people living with HIV, would it not make sense to rather test those who are not controlled? That's the one point. And the second thing about looking at people with previous history of TB. So the guidelines have been updated last year. And what you can see now is it's two separate algorithms, one for people who did not have any TB in the last 2 years, and a separate one for those who've had TB treatment in the last 2 years. So in that group, the suggestion is to submit samples for culture. But there's a whole algorithm that needs to be followed. So that's been clarified in the updated guidelines, specifically in looking at those people with previous TB. Thanks. Oh, sorry, one more thing. With regards to the Western Cape, they've been doing rigorous testing, their volumes have increased, and their positivity rate has actually decreased over time. So it's good news for that province. Thank you.
You mean the overall yield? Like they're dropping below 10%? Or the bedaquiline?
No, not resistance. I'm just talking about TB positivity. So they were sitting at about, I think, 14%, 15%. And they have decreased over time since they've increased their testing. I can't remember what the last report showed, but they're showing a decline in TB positivity with the increase in testing.
So, Farzana, I'm really glad you brought up the issue of chest X-ray and culture. I think that's the correct approach. I think anybody with a prior history of TB who's asymptomatic should have a chest X-ray and culture and a clinical evaluation. Now, how you actually do that in a primary healthcare setting, I think is a separate issue. But I think where most PHCs don't have a chest X-ray, machines, etc. Patient requires up referral. There's already a population that's unlikely, less likely to link to care complete treatment. So I think there's a lot of programmatic issues, but I think clinically that is the correct approach. You asked about testing yield in TUT. So Jeremy, cut me off whenever you want. But if I pull it up quickly. So yes, the yield was higher in people with HIV not on ART, or people with HIV who had low CD4 counts. So in people on ART, the yield was 4%. People not on ART, it was 12%. But the problem is always reach, right? So, you know, if we, I recommend that people look up some work that Mamapudi Kupchani, who's a TB modeler, has done. And so we cannot just think about yield when we think about TB testing. So yes, the yield is going to be very high in, you know, household contacts or people with HIV and uncontrolled HIV. But as you said, Farzana, that's not where the bulk of the undiagnosed and transmitting cases are. The bulk of the undiagnosed and transmitting cases are asymptomatic people without HIV. And unfortunately, they don't have clearly identifiable risk factors. So if we were designing a program around testing yield and efficiency and cost, we would only test, you know, people with uncontrolled HIV or not on ART. But even in TUT, those were a small minority of the total TB cases detected. So although the yield in people with HIV controlled HIV was low, you know, many, many more cases overall were detected in that population just because there are more people in the clinic with well-controlled HIV. And so I think there's always this push and pull between yield and efficiency and reach. You know, how are we going to find the missing cases? If we only test those with the highest yield, we're not really going to make a lot of progress. So, and then is there some basement of yield, you know, like below which it's now just too inefficient? And this is a question essentially of resource and will. You know, is it 3%? Is it 2%? At what point are we now getting into the range where we're, especially with asymptomatic people, potentially picking up more false positives than true positives, you know? And we don't know what that basement is. So, you know, we know that Western Cape should test more. KZN is testing a lot, and somewhere in between is the right magic number, but we don't really know. And then, of course, you know, all of these TUT interventions were done in the clinic. We really don't know how to target testing beyond the clinic, which is where we need to be moving towards, as you demonstrated so beautifully in the prevalence survey. You know, there's all the undetected TB is out there in the community, and people who aren't that sick and have not really had a reason to go to the clinic before, but that's the hard population to target. So, you know, Norbert, if you ask Norbert and Jekka, he'll say, we're doing 4 million tests a year, let's do 10 million. We need to test more, like not less. But I think that, you know, there's no right answer. It's like, at what point are we over testing? And are we over testing stable ART clients? I think that is something that's going to be debated in the next year or two.
Cool. All right. And then last comment perhaps from Tandi. Tandi should be able to unmute.
Oh, thanks, Jeremy. Thanks, Ribka, for a very interesting talk. Yeah, I think as soon as I typed the comment, then I realized that we have a problem of synchronization of guidelines, because this information is quite in detail in the TB recovery plan, where you have all these situations, as Farzana had indicated, if previously had TB, and then you have this, and then what happens, and, you know, the need to, you know, because when they first came out, these TUT guidelines, you know, the knee-jerk reaction, I mean, there was a lot of confusion. What do you do? Do you immediately take a GeneXpect? I mean, even a person that's never had TB, do you immediately take a GeneXpect that's positive as somebody that needs treatment now? And then I think it's nicely detailed in those guidelines that you need, you know, you need to do some things like smears are also there, quite indicated, you know, as smears, clinical assessment as well, maybe a chest x-ray. And definitely for previous TB, they stress it a lot that you have to do a culture. But the problem is these sort of guidelines are not in the HIV guide. You know, in the HIV guidelines, they just said, we've changed the screening. If these TUT groups are going to be done at GeneXpect regardless of symptoms, TB symptoms, but then there's no breakdown in those very guidelines and no reference to say, check, these TB guidelines, sort of the algorithms that's in the TB recovery plan, which also speaks to say we really need the TB guidelines to be updated as soon as possible, because we've been, waiting for those for a very long time. Thanks.
Is there a plan to update them? Because the last ones were 2014.
Yes, definitely there's a plan. That's my understanding, that there's a plan to update the guidelines, given all these diagnostic changes and all this. That's what I understood, that there's a plan to update. And the pediatric ones luckily have been updated because they were 2013. Yeah, Fazana is indicated there. There's definitely a plan, and we need the updated guidelines as soon as possible. Thank you.
Cool. Yeah, Fazana says plan to update the guidelines. Work in progress. Excuse me. Sorry. Okay, thanks. I think we can leave it there. Thank you very much again, Ribka, for really such a masterful overview of the latest in TB. So we really grateful for that, and some really exciting things coming through the TB world, which is really nice to see.